Hello, Dr. Levy. Thank you for joining us. I look forward to your presentation for our virtual conference here. So take it away.
Very good. This first topic is entitled Oral Infections Cause Most Heart Attacks. And it's really that simple. I'll show you in a moment exactly what I mean by this because the evidence is overwhelming. As in all my presentations, you sometimes see numbers after a statement or a fact, and this is a PubMed number. You go to the PubMed website as seen here, put the number in, and you'll immediately go to the abstract and sometimes the entire article. Now, the first thing to keep in mind and to consider are what are the factors that promote chronic degenerative disease. And actually, the direct final common denominator of such promoters is that they increase oxidative stress, especially inside the cell, intracellular. And the circumstances that promote this predominantly and resulting in chronic degenerative diseases are first and foremost infection-related toxins. These are actually, statistically speaking, the number one factor, far and away more than any others. Toxins unrelated to infections, toxic air, toxic food, toxic water. Inadequate antioxidant and nutrient ingestion, because these are the direct counter actors against toxins. Number four, many people have genetic deficiencies, and these compromise specific metabolic pathways that result in increased oxidative stress. And then finally, there's hormonal deficiencies or imbalances, and any deficiency of testosterone or estrogen, depending on sex, and especially of thyroid hormone, enormously promotes and increases oxidative stress throughout the body. So I like to ask the question, what do all toxins and infections have in common? Quite simply, all infections and all toxins cause cell damage and produce symptoms by the oxidation of biomolecules. And I've looked for an exception for a long time. I don't know of one. Biomolecules, what are we talking about? When we talk about biomolecules, we're talking about the molecules in the body that have metabolic functions. So these are enzymes, proteins, fats, sugars, structural molecules. It needs to always be remembered that a biomolecule can be in its normal reduced state, having a complete contingent of electrons, or it can be in an oxidized electron depleted state. And this is significant because reduced biomolecules are in a state of normal physiological function, while oxidized biomolecules are in a state of decreased to absent physiologic function. So with this in mind, then, it turns out that really all disease is increased numbers of oxidized biomolecules. Remember, the oxidized biomolecule doesn't really function, and the reduced biomolecule functions normally. So the more you have of these, and the areas where they're concentrated inside different intracellular organelles, extracellular space, cytoplasm, different tissues, and what are the properties of the oxidizing molecule, which is also a synonym for toxin. In other words, is it fat soluble, water soluble, ionic, large, small? This all determines where the oxidizing molecules go to oxidize and cause the disease. Then there's genetic defects. These are predisposing to oxidation. And then you have how long have the biomolecules been oxidized, and of a certain species of biomolecule, fat, sugar, are there minimal numbers, moderate numbers, or very large percentage numbers of these biomolecules being oxidized? Now, a few definitions. Nutrient and toxin. An antioxidant actually is a nutrient, because we all talk about nutrition and good food, and ultimately, because of the way disease is caused by oxidized biomolecules and relief is caused by reducing those oxidized biomolecules back to a normal electron state, it's only the degree to which food that you eat breaks down into molecules that have antioxidant or electron donating function that you have nutrition. So effectively then, at the molecular level, an antioxidant is a nutrient is an antioxidant. Similarly, conversely actually, a toxin, we hear lots about toxins these days, toxin this, toxin that, get rid of toxins, avoid toxins. But what's not emphasized is that all toxins have their toxic impact by their ability to take electrons away from biomolecules, either directly or indirectly. So a pro-oxidant is a toxin is a pro-oxidant. These are synonyms. Toxin also means poison. So a poison is only poisonous because of the degree to which it oxidizes a specific set and number of biomolecules. Now, with that in mind, then, these are what I would consider to be the primary treatment principles for all chronic degenerative disease. Certainly then, since we know how undesirable the pro-oxidant effects of toxins are, you want to prevent or minimize new toxin exposure. Environmental, in the diet, digestion, and really big in the dental. And we'll discuss more about that in a moment. You want to be able to neutralize existing toxins already present. You want to be able to excrete toxin stores in as non-toxic a fashion as possible. And very importantly, you want to be able to resolve or contain infectious foci and eliminate the reasons for contracting new infections, because infections are powerful, large sources of ongoing toxins and pro-oxidant substances. Then you want to supplement and eat optimally. And then, of course, you need to address hormone imbalance, deficiencies. And this is important too, because it seems like there's a lot of docs, even integrative docs, that address all the other issues, and maybe because it's a younger person, they don't check it, or if it's a very much older person, they say it's not worth dealing with. But the fact of the matter is, even subtle augmentations or restorations of deficient hormones can make everything else you're doing so much better. So my point of view on hormone imbalance and deficiency is, if the patient is worth treating, it's worth evaluating and treating the hormone deficiency. Now, I said dental was important. So in the subset of dental, you have root canal treated teeth, which are always infected, 100%. You have the pain-free but chronically abscessed tooth, which, believe it or not, is very common. You have gum infection. You have old pockets that heal over at extraction sites that actually contain gangrenous materials. That's how toxic they are. And they occur either at the old extraction site or they're present ongoing around the root tips of root canal treated teeth. Then you have chronically infected tonsils, which are virtually always present, even when the tonsils look normal, because they've been draining infected root canals and other teeth. Then infected dental implants, and finally toxic metals. All these are sources of increased oxidative stress. Now, some 20 years ago, Dr. Hal Huggins and Dr. Boyd Haley, in collaboration with dentists from around the country, examined 5,000 consecutive extracted root canal treated teeth. 100% had pathogens and highly potent pathogen-related toxins. And there were also controlled teeth extracted for orthodontic reasons that had no toxins at all. So this is how we can say quite comfortably that 100% of root canal treated teeth are infected. If you did have a non-infected one, which I don't think is physiologically possible, then you'd knock this 100% down to 99.99%. Now, it's also been well identified, and this is the reference, that root canal treated teeth continually produce toxins as the pathogens proliferate, and over 460 types of bacteria, along with fungi, viruses, protozoa, you name it, are found in these teeth. Not only are they found, we have other sources that show, other references that show these pathogens are widely different, wide array, and we can see in the literature, even though it's not really talked about that much by dentists, that these pathogens are present in the root canal treated tooth always. Another study looked at root canals and were able to sample the sites of infections and the sites of the teeth, and were able to find pathogens, the DNA of bacterial pathogens, in 100% of 34 patients. So as I mentioned before, there's no such thing as a sterile mouth, and there's no such thing as a sterile root canal. You do have, if a tooth is not infected and is normal, a sterile pulp. So the pulp should be sterile, but once you core it out for a root canal, it either starts infected or gets infected and remains infected. This happens because when you do the procedure for a root canal, you literally, like a roto-rooter, core out the nerve and blood supply and the connective tissues and the blood vessels inside the tooth, and then fill it with a substance. And the immune system then no longer has access to the tooth. I mean, a lymphocyte can't jump across the Grand Canyon, and that's what an evacuated pulp would look like to the immune system. You also get reversal of fluid flow. Normally, in a normal tooth, you have a flushing out. You have an internal mobilization of fluids going from inside out. When you have a root canal and you evacuate the pulp, that completely reverses, and you have a fluid flow from the outside polymicrobial, polypathogen environment of the mouth into the tooth. So a root canal treated tooth is only, quote, successful when you debulk the infection and eliminate the pain. And of course, you often eliminate the pain because you've taken away and clipped out and evacuated the nerve supply inside the pulp. Interesting now, for root canals and other abscess teeth, you can state that this is a perfect endogenous delivery system of pathogens and toxins into both the venous blood and the lymphatic drainage. This is actually better, if you will, than IV push, and more efficient. For the veins, and we're going to talk a lot about the heart here, when you chew on this root canal, especially when it's in a molar, you squeeze the pathogens and toxins into the draining venous blood. The venous blood is low pressure. The venous blood then works its way to the lungs, goes through the pulmonary circulation, then comes out, goes into the left ventricle, low pressure, into the, left atrium, low pressure, then into the left atrium. And after the left atrium contracts, you go from low pressure to high systolic pressure, with the coronary artery getting the plurality of the cardiac output. So the coronary artery endothelium is the first area that gets exposed to these pathogens and toxins with the delivery of high pressure. And that's why the coronary endothelium gets chronically seeded by these pathogens and toxins coming from the anatomically distant mouth. Also, for the lymphatics, there's an exchange ongoing, and this is seen in thermograms with patients with root canals. Oftentimes, you'll see red streaks going from the root canal treated teeth or other abscess tooth down through the neck and on into the breasts. And I'll submit to you that a substantial majority of breast cancer patients have infected teeth. Now, These infected teeth are always toxic, but variably toxic. This is because they each have a unique pathogen flora. The tooth involved, an incisor, you won't really put much pressure on an incisor, but a large molar you will. So the delivery into the veins and the lymphatics varies. Then there's containment. By that I mean, sometimes the abscess at the tip of the tooth stays put, and other times it cavitates and starts devouring and breaking down adjacent healthy bone, causing it to sometimes disseminate even further. And then you have how long the tooth has been present. You have how good is the nutrition and supplementation. Very importantly, how normal is the hormonal status. And then finally, you have status of the immune system and general health of the patient. If you have an elderly person with osteoporosis, you're going to have, in general, more spread of these infections in the bones of the jaw than you would in a young, healthy person. Now, the significance of this is that it is often missed. You know when you have a root canal, you've got an infected tooth. So it doesn't matter a whole lot what you see on x-ray with a root canal. But as I'm going to show you, there's a very large number of teeth that look normal on regular x-ray that in fact are infected. A regular tooth x-ray called the panoramic, you might see a reasonably sized abscess, not a tiny one, on maybe 30 to 50% of these. You have another way that gets it even more, but the real gold standard is what's now called the 3D cone beam examination, also called a 3D x-ray. This will pick up, depending on the expertise of the interpreter, upwards of 90% to nearly 100%. So you're getting a much better yield, if you will, of diagnosing abscess teeth by going with this. Very important though, because it has a lot of information on it in this test. If it's not being interpreted by you, but going to a specialist, which is probably the best way to do it, you need to tell them what you're looking for. And you need to say, we're looking for apical radiolucencies or infection of any degree on all teeth present. Here's a root canal treated tooth. You see the characteristic radio-opaque areas in the evacuated pulp. See, there's an unevacuated pulp. And nice, big, round abscess at the tooth tip. Now here's a heavily diseased tooth, but it has not been root canaled, but the cavity has finally exposed the pulp to all the polymicrobial environment of the mouth. And so we see here a large abscess, and on the other root tip, a smaller abscess. So for chronically abscessed teeth, CAT, we have studies that show, in one study, 280% higher risk of coronary artery disease in many of the patients with it. In another study, that's 530%, and there's the references you can go to. And a correlation also, not surprisingly, between, that should be CAT, between an abscess tooth and increased C-reactive protein levels. These are always correlated with increased systemic body-wide oxidative stress. Now, it's pretty much accepted that inflammation initiates and evolves atherosclerosis, and that atherosclerosis in the literature is considered to be a chronic inflammatory disease. Well, inflammation requires a pro-oxidant presence or toxins. And for coronary disease, this is the seeding of pathogens and toxins from the oral infectious sources, these infected teeth or infected gums we're talking about. But when you continue on, as the young people say, a 24/7 basis to continue to expose the body and the coronary artery to new pathogens and new toxins around the clock, the inflammation becomes chronic and it becomes the disease it was designed to prevent. As my mentor, Dr. Huggins, the founder of biological dentistry, put it to me some 25 years ago, he said, Tom, you can't dry off while you're still in the shower. Okay, drying off would mean resolving the disease, getting the atherosclerosis to stop. But if you don't stop what's provoking and causing it and making it worse, just trying to repair rather than prevent will not get you very far. But if you follow everything, as we'll see, and you stop the new seeding and you use powerful antioxidant presence to repair the oxidized biomolecules in the inflamed state of the coronary artery, you can actually reverse atherosclerosis. Now, another example of the oral pathogens that are just in and around the coronary artery and the atherosclerotic coronary artery at all times is a study that shows that the platelet clots that block off acutely an already narrowed blood vessel to cause a heart attack actually turn out to have a humongous amount of pathogens in it. 1,600% more bacterial pathogen DNA in the blood clots that acutely block off the artery to cause the heart attack than is seen in the surrounding blood. This pretty much gives us a pretty slam dunk evidence that these pathogens and their ability to provoke acute vessel occlusion, in addition to growing the atherosclerotic plaque itself, is a cause and effect relationship between the pathogens and the blood clots, and not just a correlation or association or link or any of the other terms that you see in the literature when they just don't want to take the next logical step. Now, to me, this is an overwhelmingly important and critical study here. In patients known to have coronary artery disease and coronary arterial atherosclerotic narrowings, they did an atherectomy procedure. This is like a blood vessel roto-rooter. They actually scrape out the obstructing plaque and then examine that plaque with PCR testing, looking for pathogen, DNA, nucleic acid. Well, in this study, they looked at 38 of these people. They found over 50 different types of bacterial signatures, mostly oral, and it was present in 38 out of 38. Now, they also looked at normal blood vessels. There were no pathogens there. So 38 out of 38 patients with atherosclerotic plaque had high levels of oral pathogens in it. And as I like to say sarcastically, 38 out of 38 is pretty close to 100%. And that's why in the title of my book, Hidden Epidemic, Silent Infections Cause Most Heart Attacks and Breast Cancers, that most really means greater than 95%. Here are other studies that show these oral pathogens are present in coronary atherosclerotic plaque. Periodontal or gum disease also has this same array of pathogens being swallowed, being released into the blood, and to a lesser degree into the lymph system. And it's long been recognized now that periodontal disease, gum infection, is an independent risk factor for coronary artery disease. Now, how common are these chronically abscessed teeth that do not hurt? They're asymptomatic. Well, when you crunch all the data down, and there are a lot of studies around the world on this, 3D examination, you would expect to find this on nearly all root canal treated teeth, and at least 9% and probably as much as 20% of all teeth in the general adult population that have not been root canaled have chronic abscesses. This is an astronomical number. You know, I ran across a dentist at a conference and he had just gotten his 3D machine and he's saying, well, I'm seeing these abscesses all over the place. What am I supposed to do? I mean, these are infected teeth, and one infected tooth will cause and promote virtually any chronic disease you can imagine, especially heart disease and especially cancer. Also, we see these oral pathogens occurring in the cerebrovascular arteries, just like in the coronary arteries, and we see them in a majority of intracranial aneurysm specimens at surgery. Also present in the periodontal fluid, in postmortem exams of patients with coronary disease, and the worse the coronary disease was while the patient was alive, the greater the total amount of pathogen-related DNA was found in the pericardial fluid. So these pathogens go everywhere. I don't have all the studies for you here, but you swallow them, obviously, and these relate to gastrointestinal conditions and cancers. We've seen them in tissue specimens of Alzheimer's patients. I believe, it's my opinion, that most chronic disease that's not responding readily to a good therapy is because there's a colonization of pathogens, not to the degree of an abscess, but a colonization of pathogens in those tissues, continually producing a lot of toxins and keeping the oxidative stress high in the diseased tissue. Back in the 50s, Dr. Joseph Issos found that 98%, considered it was the 50s and he didn't have sophisticated testing, you could pretty much call this 100%, of his advanced adult cancer patients had between 2 and 10 dead teeth, and he characterized the root canal as a dead tooth. So this is a pretty powerful statement all by itself. So what do we do about this? Well, a regular Panorex mouth x-ray misses a lot of infectious pathologies. I submit to you that the 3D examination should be an integral part of the routine baseline evaluation of any chronic degenerative disease patient, but absolutely of every disease with documented or suspected heart disease and or cancer. 100%. I consider it, with the evidence we have now, malpractice to treat a patient with that condition and not have their mouth properly evaluated. Remember, you don't know someone has diabetes until you measure their blood sugar. They don't walk into the office and you just say, wow, you've got a blood sugar of 400. You got to look for it. A regular x-ray, you can see how much overlap there is. You're not going to see much. Here's a cone beam examination. You can see a root canal treated tooth, big abscess, erosion away of the bony wall of the sinus, and filling up the sinus with fluid and pus. A majority of chronic sinusitis patients have infected teeth in their upper jaw or maxilla. Here's another one. These are crown teeth, but no root canals, huge abscess, big, huge abscess, eroding away the bony wall, filling the sinus. So I would submit to you that the single most important cause of atherosclerosis and heart attacks, and the single most important cause of cancer of the head, neck, chest, and breast, is the chronically infected tooth, either in the form of a root canal or an asymptomatically chronically abscessed tooth. So, and finally, the same organisms exist in periodontal disease as in these infected teeth, except the infected teeth have more of them. Well, these are studies where there's very close to being a cause and effect, or just a strong correlation between gum disease and degenerative disease. So I submit to you that the correlation with an infected tooth is even higher, and that's increased all-cause mortality, coronary disease, metabolic syndrome and diabetes, high blood pressure, cerebrovascular disease, stroke, vascular disease in general, pulmonary disease, arthritis, osteoporosis, inflammatory bowel disease, kidney, collagen vascular disease, all the major neurologic diseases, all the major cancers. So this is important. These are not inconsequential findings, and they show how critical this is to health in general. The tonsils drain these teeth, and although it's an important topic, I can just tell you, even though the tonsils appear normal, If a tonsillectomy is not done, virtually all these patients should get a sequence of intratonsillar ozone injections, and this can help clear up the infection inside the tonsils. So remember, an asymptomatic abscess tooth cannot be diagnosed if you don't look for it, okay? And it's a powerful cause for heart attack as well as breast cancer. So never miss the opportunity to do this 3D test. I make this point too. You have sick children. It's just as important in a child with leukemia, 5-year-old, to get this 3D scan of the teeth, because an infected tooth could be the only thing that's separating that child from early death or a lot of horrible chemotherapy versus a complete cure and resolution of that condition. So I would say you can expect atherosclerosis to significantly reverse most of the time when you get rid of the ongoing new toxin sources and you do proper therapy. And this is my contact information. Thank you very much.
The Canadian Association of Clinical Thermography is dedicated to making thermography more accessible and available to those who seek it. Become a supporting member today and help us transform the way medical thermography is understood in our world by practitioners and the general public. Visit us today and join us.